Hi, hello everyone. Welcome to Dr. Ravichandra Official. Please like, share, and subscribe Dr. Ravichandra Official for more interesting pathology videos. Today we will discuss a important topic in hematology, that is RBC disorders. RBC disorders or erythrocyte disorders is based on RBC concentration, whether it is increased or decreased. If it is decreased, the condition is called as anemia. And if it is increased, it is called as polycythemia vera. The cause for polycythemia vera can be JAK2 mutations, whereas for the causes for anemia may be multiple: bone marrow failure, systemic disorders, abnormal iron metabolism, abnormal hemoglobin development, and the list goes on. What is anemia? The functional definition is there will be decrease in the oxygen carrying capacity of the blood in anemia, decreased red blood cell number or function. There are about five causes for anemia. First one will be disorders of iron kinetics and heme metabolism. Second one is defects of DNA metabolism. Third one is bone marrow failure. Fourth one is increased destruction of the erythrocytes. And the fifth is structural defects of hemoglobin. Now we will discuss disorders of iron kinetics and heme metabolism. It can be iron deficiency anemia, anemia of chronic inflammation, sideroblastic anemia. In the normally there will be oxygen transport and there will be ferritin levels and transferrin saturation and hemoglobin concentration to maintain the RBC hemoglobin content and iron content. And in iron deficiency anemia, there will be inadequate stores, and because of the poor diet, the iron deficiency anemia will be caused. Impaired iron mobilization, chronic diseases like rheumatoid arthritis, tuberculosis, HIV, carcinomas will cause anemia of chronic inflammation. Presence of non-heme iron in developing RBCs when chemicals like lead poisoning, etc. occur, there will be sideroblastic anemias. What are all the hematological tests to detect this anemias because of the defect in iron kinetics or heme metabolism? Hemoglobin. Generally, there will be 90% of the iron stores. So, by assessing this hemoglobin, we can check the iron stores. Serum ferritin will reflect the body tissue iron stores. And serum iron is a sensitive indicator for iron depletion. And total iron binding capacity, TIBC, will measure the blood's capacity to bind iron with transferrin. The hemoglobin will be decreased in all the iron deficiency anemias, anemia of chronic inflammation, and sideroblastic anemia. When coming to serum ferritin, it is decreased in iron deficiency anemia and it can be increased or normal in anemia of chronic inflammation, and it is increased in sideroblastic anemia. Serum iron levels will be normal or decreased in iron deficiency anemia, whereas it is decreased in anemia of chronic inflammation and it is increased in sideroblastic anemia. Total iron binding capacity is increased in iron deficiency anemia and decreased in anemia of chronic inflammation, whereas it is increased or it will be normal in sideroblastic anemias. Blood picture will be microcytes will be there, hypochromasia will be seen, anisocytosis will be there in iron deficiency anemia. Anemia of chronic inflammation will normally be looking like normocytic, normochromic. In sideroblastic anemia, normocytic, normochromic, red blood cells are there. Few ringed sideroblasts can be seen. Cabot rings can be seen. Basophilic stabilin can be seen. Pappenheimer bodies can be seen. In a nutshell, in iron deficiency anemia, hemoglobin, serum iron, serum ferritin will decrease and DIBC, total iron binding capacity, will increase. Whereas in sideroblastic anemia, hemoglobin is decreased, serum ferritin, serum iron and total iron binding capacity will be increased. Both are opposite in serum ferritin, serum iron and total binding iron binding capacities. Next coming cause is anemia because of the defects of the DNA metabolism. Anemia caused by defects of DNA metabolism can be because of impaired DNA metabolism, if there is any effects in hematopoietic tissues, and megaloblastic anemia. Megaloblastic anemia causes will be folate deficiency, vitamin B12 deficiency, and other diseases. Pernicious anemias will be it is lack of intrinsic factor in the stomach secretions. Screening test will be we have to check for the peripheral smear or blood picture where you can appreciate ovulocytes, dacrocytes, macrocytes, Havel-Jolly bodies and hypersegmented neutrophils. Diagnostic test bone marrow examination is a confirmatory test and presence of megaloblasts and pancytopenia is characteristic feature of in defects of DNA metabolism. Next entity that we are going to discuss is anemia cause bone marrow failure. Anemia of bone marrow failure, there will be decreased blood cell production. Example is aplastic anemia. There will be pancytopenia. All the RBC, WBC and platelet counts will be decreased in this condition. The causes will be there may be a destruction of hematopoietic stem cells or premature apoptosis or apoptosis of hematopoietic stem cells, ineffective hematopoiesis, disruption of the bone marrow, decreased production of hematopoietic growth factors and related hormones, or loss of normal hematopoietic tissue. If you observe the picture in the first one where we were showing healthy bone marrow, and in the other picture there is aplastic anemia showing the pancytopenia. Only you can appreciate the fat cells. Anemia of bone marrow failure. If there is failure of bone marrow production, it results in aplastic anemia. Increased destruction of blood cells is there. Paroxysmal nocturnal hemoglobinuria. If there is ineffective hematopoiesis, it results in myelodysplastic syndromes and megaloblastic anemia. Bone marrow infiltration is seen in acute leukemias and hairy cell leukemias. Bone marrow hypoplasia will be observed in Fanconi's anemia, dyskeratosis congenita, diamond black fan syndrome, Schwann-Bodian diamond syndrome. And ineffective hematopoiesis is also seen in congenital dyserythropoietic anemia. So, ineffective hematopoiesis can be observed in myelodysplastic syndromes, megaloblastic anemia, and congenital dyserythropoietic anemias. Characteristic features of a aplastic anemia will be there will be pancytopenia and there will be decreased reticulocyte count. Reticulocytopenia, there will be hypocellular bone marrow and all the hematopoietic stem cells are depleted. Next cause of anemia is increased destruction of erythrocytes. Hemolysis. Lysis means rupturing of red blood cells. There will be reduced number of cells, reduced oxygenation. In hemolytic anemia, there will be Rate of RBC destruction exceeding the increased rate of RBC production. Anemia due to destruction of erythrocytes can be classified as acute and chronic, or inherited and acquired, or intrinsic and extrinsic factors, or intravascular or extravascular and macrophage mediated. Acute versus chronic. Acute will be rapid in onset, whereas chronic will be there will be hemolytic crisis over the time. Inherited versus acquired. Inherited is genetic and acquired is obtained or developed later. Intrinsic versus extrinsic. Intrinsic is because of the RBC defects, whereas the extrinsic is because of the external agents that are causing anemia. Intravascular versus extravascular, and fragmentation versus macrophage mediated. In the intravascular fragmentation, it will happen within the bloodstream, whereas extravascular macrophage mediated is outside the blood vessels. The extrinsic defects and intrinsic defects, and intravascular hemolysis and extravascular hemolysis. Intravascular hemolysis predominantly fragmentation, and predominantly macrophage mediated is extravascular hemolysis. So agents from outside the RBC, external factors or extrinsic defects, immune hemolysis, cold antibody, microangiopathic hemolysis or microangiopathic hemolytic anemias, MAHA, infectious agents like malaria parasite, thermal injury, chemicals and drugs, sometimes venoms, and prosthetic heart valves that will cause intravascular hemolysis. And the extrinsic defects which will cause extravascular hemolysis will be immune hemolysis because of warm antibodies and few drugs. Membrane abnormalities that are causing intravascular hemolysis and extravascular hemolysis will be spur cells of anemia of severe liver disease and paroxysmal nocturnal hemoglobinuria or PNH will cause intravascular hemolysis, and hereditary membrane defects, elliptocytosis, spherocytosis will cause extravascular hemolysis. Abnormalities of the RBC's interior. Intrinsic defects will be enzymatic defects such as G6PD, glucose 6 phosphate dehydrogenase deficiency, globin abnormalities like sickle cell anemias, thalassemias, alpha thalassemias, beta thalassemias, and so on. Hereditary membrane defects, G6PD deficiency, and globin abnormalities will come under hereditary conditions, and remaining all the other factors or the effects that are causing hemolysis will come under acquired conditions. And among these, prosthetic heart valves, Purcell anemia of severe liver disease, hereditary membrane defects, and globin abnormalities such as sickle cell anemias and thalassemias indicates chronic hemolysis. Remaining are acute or episodic hemolysis. In the blood picture, where there is anemia due to destruction of erythrocytes, you can observe spherocytes, elliptocytes, ovulocytes, acanthocytes, Burr cells, keratocytes, cystocytes, blister cells, bite cells, hinge bodies, RBC agglutination, and jaundice. For all the poikilocytosis conditions, you can watch my video RBC abnormalities, which is in my YouTube channel Dr. Ravichandra Official. So these are the various pictures of the poikilocytes that are causing that are resulted because of the destruction of the erythrocytes. Next, Coming cause for anemia is structural defects in the hemoglobin. Anemia due to abnormal globin component or hemoglobinopathies. Hemoglobinopathies is opathy is a disease state involving the hemoglobin molecule, and their genetic mutation will affect the globin molecule synthesis. Hemoglobinopathies comes under structural defects, so they are qualitative defects, whereas thalassemias come under quantitative defects. Sickle cell anemia, because of a homozygous condition, there will be abnormal hemoglobin, hemoglobin S, and hemoglobin solubility test shows positivity, and the red blood cell morphology will be there will be sickle cells, target cells, nucleated RBCs, polychromasia, Alveoli bodies, and basophilic stimuli. Hemoglobin C disease, which is a homozygous condition, is because of the abnormal hemoglobin C, and this is negative for hemoglobin solubility test. You can observe hemoglobin C crystals, target cells, nucleated red blood cells, occasionally some microcytes in this hemoglobin C disease in the peripheral smear. There is one more entity called as hemoglobin C Georgetown, where there is abnormal hemoglobin HbC HARTM or HbS, and this is also showing positive for hemoglobin solubility test. There will be target cells in the peripheral smear. Anemia due to abnormal globin component, thalassemia states. It can be alpha thalassemias or beta thalassemias. In a normal thalassemia state, there will be all the genotypes. Number of functional genes will be 4, and there will be normal laboratory findings. In silent carrier state of thalassemias, there will be 3 functional genes and there will be no hematologic abnormalities. Coming to the thalassemia trait, there will be 2 functional genes alphas, and these are asymptomatic, or sometimes mild microcytic anemia can be observed. In hemoglobin H disease, there will be only one functional alpha gene, and there will be mild to moderate microcytic anemia and HbH inclusions in the peripheral smear. Alpha thalassemia major, there will be no functional genes, hemoglobin BOT or hydrops fetalis condition is comes under alpha thalassemia major. There will be microcytic hypochromic red blood cells along with few nucleated RBCs seen in the peripheral smear. Coming to anemia due to abnormal globin development, thalassemia state because of the beta chains. In the normal beta thalassemia state, there will be normal laboratory findings, and silent carrier, there will be no hematological abnormalities, just like alpha carrier, silent carrier. And in beta thalassemia minor or trait, there will be asymptomatic conditions or mild microcytic anemia is seen along with poikilocytosis and basophilic stippling. In beta thalassemia major, there will be severe anemia, microcytosis, hypochromasia will be seen, anisocytosis and poikilocytosis is seen, and there will be inclusion bodies. In beta thalassemia intermedia, there will be minimal symptoms and there will be severe exercise intolerance. So out of this, beta thalassemia major will have more morbid effects when compared to other thalassemias. Thank you for patient listening. Please like, share, and subscribe Dr. Ravichandra Official for such interesting videos in pathology.